Now, finally, for this session, we have a presentation from two people. We've got Carolyn Pinto and Kelly Wilton, and Carolyn is the Secretary of the Hemispherectomy Foundation Australia and mother to a young adult daughter who underwent a right hemispherectomy in 2010 due to Rasmussen's encephalitis. Carolyn is now a research associate of the MCRI following a long career in government health and human services policy and program design, implementation and management. Welcome, Carolyn. And she's joined by Kelly Wilton, who's sitting here in the front. Kelly is the president of the Hemispherectomy Foundation Australia, a health promotion charity dedicated to supporting children, young people and their families impacted by this type of surgery. As a mother to a 13-year-old Mikey, who underwent a left hemispherectomy in 2017 due to hemiconvulsion hemiplegia epilepsy syndrome, Kelly is passionate about providing resources, community connections and advocacy for families navigating life after this type of surgery. So welcome, Carolyn and Kelly. Start with Carolyn and then she'll hand over to Kelly. Thank you very much.
Thank you very much, Tom, and I'm very conscious that we are the lucky last session of the day and we are standing between you and your evening, so I do hope that you find our presentation engaging. I'd also like to say that Kelly and I are not clinicians, so be kind to us. So as Tom indicated, our presentation focuses on hemispherectomy, a surgery which is the most radical of all epilepsy surgeries. But I will say that many of the ethical issues that will be raised in our presentation today also apply to other epilepsy surgeries, where the surgery may result in seizure reduction or seizure freedom, but involves some deficits or loss of function to the child. And you're making that decision about whether the price of those deficits, loss of function, is worth it for that seizure freedom. So in our presentation, we will be presenting some case studies that we think illustrate the ethical challenges of hemispherectomy surgery. Each of these are presented with permission, and they're our stories. They're the story of my daughter, they're the story of Kelly's son, and they're the story of Sam, one of our dads in our community, who is also a very talented graphic designer who's helped us with our presentation today. So just bear with me. So that's us. As Tom said, I'm the Secretary of the Hemispherectomy Foundation and Kelly is the President. Okay, so... and that is baby Eleanor, Sam's young daughter, who had a hemispherectomy at the age of 4, and we'll be presenting her story as well. So what exactly is a hemispherectomy? Well, as I said, it is the most radical of all epilepsy surgeries. It is the complete disconnection or removal of one brain hemisphere. So we use the term hemispherectomy as an umbrella term. So it can be done in a number of ways. You can actually, via an anatomical hemispherectomy, remove the whole hemisphere, so it's completely cut and disconnected from the other hemisphere and removed. Or more commonly, now functional hemispherectomies or hemispherotomies are done, where the hemisphere remains intact, but they're completely disconnected from the other hemisphere. So the difference between a functional hemispherectomy and a hemispherotomy is really just the amount of tissue that's taken from that affected side. It can either be a small amount of tissue or a very minimal amount of tissue in a hemispherotomy. So why is hemispherectomy performed? As you can appreciate, it's a very, very radical surgery and not one that is undertaken lightly. But for cases where children have severe, intractable, we often call it catastrophic epilepsy, arising from one brain hemisphere. So that seizure activity is such that it is firing all the time. You know, so that good side of the brain is never getting the opportunity to develop properly because of the impact of those ongoing seizures in that affected hemisphere. That's when a hemispherectomy will be considered and performed. So there's a number of etiologies in which that will occur. Rasmussen's encephalitis, which you heard Tom mention, was the case for my daughter. Stroke, sometimes babies can have an intrautero stroke in which so much of one hemisphere is damaged that they can be born seizing. We've had parents mothers say to us, I thought my baby was just a particularly hiccupy baby, but what was happening is that they were seizing into utero. There are other etiologies such as Sturge-Weber syndrome, hemimegaencephaly that Kelly will talk about, HHE and infantile spasms, all caused by significant brain malformations on one side of the brain that really cause, as I said, this intractable catastrophic epilepsy. So, a little bit about us. The Hemispherectomy Foundation Australia, that's some of our families. We have a biennial conference, so that was the conference from a couple of years ago. So we are a community of families that have all been impacted by hemispherectomy surgery. So there's some of our purple as our colour. So the young people that you see there in purple have all had hemispherectomy surgery, and we like to call them our hemi heroes. And a bit about us. So we are a registered charity. We were formed back in 2013 by a parent that went to the United States, where they've had a hemispherectomy foundation in operation for quite a number of years. And that parent went and thought, we need something like that in Australia. Families shouldn't feel as isolated and overwhelmed as they do when they're told that their child may need a hemispherectomy. So she came back and reached out to the paediatric hospitals that perform hemispherectomy, asked them to contact their families, and from then we grew. Since then we've have an online support group, we have a website, we have peer supporters that are trained, we host biennial conferences, as I mentioned, in which we have national and international speakers come and talk on topics specific to hemispherectomy, children and young people and their families. And we're in the process of developing a whole raft of resources to support hemispherectomy families. And we do it because we never want our families to feel alone in their journey. Because as you can imagine, when you hear the enormity of what hemispherectomy involves, there is considerable trauma in being told that your child needs to have half their brain removed. There's shock. One parent told me that she vomited when she heard her doctor say that her child would need hemispherectomy. There's fear. One parent said to me, "You're not doing that to my child. That's Frankenstein-type medicine." Denial. That was me. "You won't be doing that to my daughter." When I was told that the disease that my daughter had, I was told that that's what she suspected to have, Rasmussen's encephalitis. Don't go home and Google it, I was told. Well, of course, that didn't happen. And I went home and I read that the only cure for Rasmussen's encephalitis is a hemispherectomy. I think I stayed on the internet until about 2 a.m. that night, but I was convinced they won't be doing that to my daughter. So, the hemispherectomy, what's the promise and what's the price? So the promise, of course, is seizure freedom or seizure reduction. As I mentioned, hemispherectomy is confined to children with the most severe type of epilepsies, catastrophic epilepsies, where that other hemisphere is not getting the chance to develop. So the cognition is stalled or declined. My daughter's was definitely declining with the progression of her disease. And you're after behavioural improvement. Seizures anti-epileptic medications, and our kids are on a bucket. They can be on 2, 3, 4, 5, 6, 7 anti-epileptic medications. So this is what you're wanting to achieve from hemispherectomy, seizure freedom. So about 50 to 85% of children after hemispherectomy will never have a seizure. My daughter's last seizure was the one she was having as she was being wheeled into theatre. And the remainder will have significant reduction in seizure, depending on the etiology. Some etiologies do better in terms of seizure freedom than others, but most children will either be seizure-free or have a significant reduction. What's the price? It's pretty significant. Hemiplegia, dense hemiplegia. So every child, this is a given, will have a dense hemiplegia after a hemispherectomy. So the side opposite to the hemisphere that's removed will be permanently paralysed. Most children will become ambulatory and walk with an orthosis, but they will never regain fine motor function or pretty much any function in their affected hand. Some children can use their affected arm as a bit of a helper, but the hemiplegia is a dense one. Vision. They have a hemiopia, so they lose vision, peripheral vision on one side, and they lose a visual field in their centre of their eyes. Most kids adapt pretty well to that, but it's an ongoing safety risk. I know it is for my daughter, the fact that she hasn't got any peripheral vision. Surgical management of spasticity is a given for our kids for the rest of their lives. Botox and splinting can only do so much for dense hemiplegias, so all our kids will require surgical management for their spasticity. They'll be dealing with subluxation issues for the rest of their lives, hip, shoulders, all features of their lives ongoing. Hemiopia, I mentioned, if it's the dominant hemisphere where language is centred, they can lose speech depending on how young the child is, and that's a big ethical issue around the timing of surgery. What do you do? If a child presents needing surgery at the age of 5, no other physical deficits, but you know that the window for language transfer is going to close. We all talk about plasticity, but plasticity only stretches so far. And with language, you really need a child to have a hemispherectomy before the age of 8 or 9 to get good language transfer. And we know that's not happening for quite a number of our children. And non-dominant hemisphere, like my daughter, quite significant visual spatial deficits. Spatial, she's really not good in crowds, and other kind of spatial deficits that affect her safety, being able to judge the distance of cars, approaching cars, for example. So depending on the hemisphere that's removed, there are going to be considerable deficits, in addition to the hemiopia and the hemiplegia. So, some of the ethical issues in hemispherectomy, it's that balance. When is the epilepsy bad enough to warrant taking out half a child's brain? Who makes that decision? It's very subjective. Quality of life. We as parents know how poor the quality of life our children can be prior to surgery. We're talking about children that aren't having a seizure once a week. On a good day, my daughter would have 3 or 4 seizures a day. On a bad, it would be hundreds. The effect of all those anti-epileptic medications. At the time my daughter went to surgery, she was on 6. Each one of those designed to dampen the activity in the brain, slow it down. All of them having behavioural impacts. Children can become irritable, angry, aggressive, withdrawn. I'm seeing lots of not. I'm sure I'm telling you nothing that you all, as clinicians, don't know. When should we consider medical treatment futile? When should we say enough's enough? It's not working. This is a progressive disease. Time to do the surgery. Again, really, really hard, particularly in the context of a neurologically intact child without any physical deficits. Trauma, the trauma of that, the uncontrolled epilepsy. I will never get over the fact my daughter's epilepsy. She's been seizure-free for 15 years, but it took me about 5 years before I didn't startle when I heard a bang in the house, because I was thinking, she's gone down again. What about the siblings and the parents and the wider family? How do you support parents with their decision-making? It's often being left up to parents to make that decision. And please don't interpret anything that I'm saying as criticisms of the clinicians that were involved in the care of our children, because we know these are incredibly hard decisions. We're all muddling through, and they're doing what they think is best for the child. But as you can see, some of those decisions are incredibly subjective, particularly around quality of life considerations. And the voice of the child. When should we be listening to our child when they've said they've had enough? So I told you that we would present a few stories just to illustrate some of the ethical considerations. And this is my story, the story about my daughter Freya, who up until the age of 6 had a perfectly normal childhood. There was nothing in her early childhood to indicate that what was around the corner for us at all, completely oblivious to in fact, if anything, she was too healthy. She rarely got sick, and in hindsight, I think there was probably something happening in terms of her immune system, because Rasmussen's encephalitis is widely considered to be an autoimmune condition in which the brain starts attacking one healthy hemisphere. They don't know why, but it turns on itself and it starts producing antibodies and attacking. Why it's only one brain hemisphere, we don't know, but it's a particularly cruel disease because it starts attacking one area of the brain and you'll start getting seizure activity from that area, then it'll move on to the next. So her seizure presentations were always changing. So her first seizure was at the age of 6. That second photo there, I'll never forget, we're on holiday at the time in Byron Bay, and we didn't know she was having seizures. Her face was twitching, she couldn't control her saliva, so she was drooling. We took her to 3 GPs while we're up in Byron Bay, and they all said, probably a virus. See your own GP when you get home. We took her to our GP as soon as we got home. She said, I don't like the look of this, I think you should go to the Royal Children's. We spent all day in the ED, as you often do, but we saw a neurologist who took one look at her and said she's having seizures. And she was admitted, and they saw an area of atrophy in one area of her brain, but they didn't make too much of it, and she was put on some anti-epileptic medication that controlled the seizures pretty well for about 6 months. And that was the pattern for the next few years, although the number of anti-epileptic medications continued to be upped. And she was pretty miserable. So I look back on those photos and I see a child with dark circles under her eyes, pretty miserable. The third one there with the helmet was during one of her many hospitalisations. By that stage having drop attacks, so helmet needed for her safety. But all that time, often long periods where she couldn't go to school. She didn't go to parties or sleepovers. As I said, the effects of all those anti-epileptic medications made her cranky, sad, irritable. One made her aggressive. She'd never had an aggressive outburst in her life prior to that. We were trying intravenous IVIG. We tried a novel therapy, and that was at my research. I said, they're trying this overseas, can we try it here? And the clinicians agreed to give it a go. It didn't work. By the age of about 9, she was saying she's had enough. And by the age of 11, she was really sick. So she was no longer attending school. She was home with us. I couldn't work. any longer, and she went to surgery. She spent about 3 weeks in the Royal Children's before her hemispherectomy, having hundreds of seizures a day. I was going through some old notes the other day and I saw her manual seizure chart. They're probably all on an app now, but it was literally hundreds. Every few minutes she would have a seizure. The whole left side of her body was convulsing 24/7. That was her immediately after surgery, still for the first time in about 2 years. But better days have come. The rehab journey has been pretty tough, but there's our girl now. She's defied every expectation. After being told that it would probably be a struggle for her to go back to mainstream school, we persisted. She did that. She kept keeping up. She finished VCE with a good ATAR. She got enough of an ATAR to enrol in speech therapy at La Trobe University. She now has a Master's of Speech Therapy and is a practicing speech pathologist and lives independently, living her best life, a life that she could never have had with all those seizures. And little Eleanor, Sam, our graphic designer's beautiful baby daughter, she was a twin who's experienced twin-to-twin transfusion syndrome. Like many children that proceed to hemispherectomy, she had an intrautero stroke and proceeded to have lots and lots of seizures. So in the first year of her life, she had 3 surgeries, lots of medications, multiple hospital admissions, but the hospital was given her age. She also had quadriplegic cerebral palsy, to continue to trial AEDs to control the seizures. The family sought another opinion. The second opinion said a hemispherectomy was the best option for Eleanor. Sam and his family took that opinion back to their own hospital, who agreed with that opinion, and she went to a hemispherectomy there, and now she's age 6 and she's beautiful and she's living her best life too. So you can understand why our motto is hope in one hemisphere. Thank you, and I will pass on to Kelly to talk more and tell her story.
Thank you, Carolyn. I'm also aware of time, so thank you so much, everyone, for sticking for the very last session of the day. And also, I know we're getting close to 5 o'clock, and that's generally when my son, Mikey, will call me, so my phone will probably go off. That is my son, Mikey, up there. As Carolyn said, we are not clinicians, but we are parents with lived experience with children who have had a hemispherectomy. Mikey had his hemispherectomy just before he was 6 years of age. He had a prolonged seizure at 10 months of age, and shortly after was misdiagnosed as having a stroke. At 2 years of age, he was formally diagnosed with HHE syndrome, hemiplegia, hemiconvulsion epilepsy syndrome. And by the time surgery occurred, Mikey had been on 8 different medications, and so just before he was 6, he had a functional hemispherectomy with a resection 2 years later for misconnections. But I'm very happy to say that Mikey is about to have his 14th birthday. He's also living his best life on the Gold Coast. He has many social activities and hobbies. He loves riding his motorbike. He loves riding the roller coasters at Movie World every other weekend with his support workers. And he also loves indoor skydiving, as you can see on that photo there. So I'll be speaking about the family experience, a trauma-informed lens, and why this needs to be sort of looked at for our families. We know that when families are experiencing trauma, like watching your child have hundreds of seizures and not being able to do anything about it, that parents, we're scared, we're overwhelmed, and we actually miss a lot of vital information. In fact, by the time we see our clinicians, we miss about 60% of what you tell us. So it's not that we're not listening, it's that we literally cannot take in the information. We are in a trauma response and we're overwhelmed, and it's very, very difficult for us to take in the information that our child will need a hemispherectomy. So what are we missing and what do we need? We know that our families need clear, plain language. Ethical issues do arise when not using plain language to inform parents to know what their choices are. Many of us, when we are told that our child needs a hemi surgery, we're told to then go home and think about it. Of course, many of us say no. Carolyn just said, absolutely not. You won't be doing this surgery on my daughter. My husband said the same. He's not coming near our son. And that's the immediate response, and that is a lot of our families all say the same thing. And can you blame us? It sounds barbaric, and it's just too much with what we've already experienced to put one other layer of complexity onto our child that's already having these seizures just seems cruel. And we as parents don't understand the benefits as well as the risks because we can't take in that information. And also, we have a false sense of that we have time on our side, that maybe if we throw some more medications, we will get that one special medication that will all of a sudden make our child's seizures go away. But of course, we actually know that is pointless with children who are a candidate for this type of surgery. We know from research that if 2 meds don't work, the chances of a third one working is less than 8%. So in the meantime, children with catastrophic epilepsy are being impaired by not only the seizures, but also the side effects of the medications. Kids are unable to learn, and as our neurologist said to us, they can't learn. Your son can't learn while his brain is on fire. Families can't work when you need to care for your child and your other children. So there are financial pressures, there's mental health, well-being of the whole family. Parents need to make informed and ethical choices of their child's potential surgery, and sometimes, again, we're unable to do this because we have this false idea that we have this magic time on our side. But by not doing the surgery and delaying the surgery, we risk our child's life further declining, and the risk of SUDEP is very high, and a lot of us don't understand that, and even mentioning SUDEP is very confronting for so many parents to take that on board. And in fact, by the time surgery does come around, when we have delayed it, we are talking about no other options. We've exhausted all the medications, all the therapies, the special diets, all the things that we might have heard in an online chat room from someone overseas. Their time is up and it's time for surgery. Definite impairments, as Carolyn mentioned before, with the hemiplegia, cognitive decline, dysfunction, changes in that. However, it does equate to a life without catastrophic seizures. We find that many of our kids with certain seizure disorders, they already have a hemiplegia, like my son Mikey. He already had cognitive and language impairments prior to surgery. However, by proceeding with surgery, they have a chance for development on that good side of the brain. That took my husband and I about 4 years to understand that. We did seek second opinion. Our neurologist said, please go and get a second opinion. Which we did. We had different lots of information. So we did delay surgery 4 years. And it's something that at the time you make the best decision that you can. But what we're finding that if we can help families going forward, making supported decisions with their surgical team and clinicians, and we can bridge the gap with fellow peers who have already walked this path with them, plus with the up-to-date research that is now here, that it wasn't particularly 10 years ago, we can help them make an informed decision, and the parents will feel bit more empowered with the information that they're receiving. Have I just done something to... Oh no. Yeah, tech's not my big thing, sorry. So next is understanding the young person voice in a hair hysterectomy surgery. Of course, it's really hard for babies, young children. They're not able to make an informed decision. So it's up to the parents, it's up to the clinicians, neuro team. And when we talk about hysterectomy surgery, it's easy to focus on the medical side, but the child is more than their condition, and listening to their voice is powerful. It reduces their fear, it builds trust, and it helps them feel safe and respected. And as we all know in this room, the disability community's message is clear. It's nothing about us without us. So when we can ask a young person in an appropriate way that's suitable for them, we can simply ask the question, do you want your seizures to stop? And remembering this child's life has dramatically shrunk. So for many kids, they're already experiencing debilitating seizures. They're cognitively impaired. The decline is happening before their parents' eyes. They're socially excluded from perhaps once a bustling social life of school friends and events like birthday parties and sporting activities, and now they're not being included at all. So there is life after surgery, and the more you preserve the good part of the brain, you can move forward with that life. So if we're able to convey that to families, to children in an appropriate way, we can simply ask them, do you want your seizures to stop? When Freya was asked the question, Carolyn's daughter, Freya said, make them stop. And Mikey, even though he was essentially non-verbal, we asked him, Mikey, do you want your seizures to stop? And he said, yes, stop. So we did the social story, we got him ready, but he'd already been out of hospital that many times anyway, that it was one more, but this time we had a bit of hope when surgery day came, because we said to him, your seizures will stop, hopefully, fingers crossed. We know that nothing's 100%, but we knew we had a chance and we'd exhausted everything. So remembering that we're at the point now where it's now or never, and we risk losing him. So it was no option. We went ahead with it. And we also know that Mikey, as well as Freya and many of the children who are a little bit older, they know that they're not living a life typical to even their siblings. They might be confined to one room of the house. They see their brothers and sisters running around. They have anxiety. The child having the seizures has anxiety. They can't communicate in the way that they want to. They're frustrated. So they know that their life is pretty shit, if I can say that, which I am. And so they deserve a childhood. And we believe as parents that they shouldn't be robbed by that debilitating illness of the brain. If we get rid of the illness, the wellness can start, and the child and the family can move forward with their life. I'm very happy to say that the Hysterectomy Foundation Australia is in collaboration with the Paediatric Epilepsy Surgery Alliance, and they're based in the US. They are founded by Monica Jones, who is also the primary investigator for the Global Paediatric Epilepsy Surgery Registry, and that is a peer-driven research collaboration with parents and young adults who have had hysterectomy surgery. From the registry, 85% of families, there's 199 families who have all had hysterectomy surgery around the world. 85% of that family all say that life is better post-hysterectomy. So there is a real hope in one hemisphere, as Carolyn said before. And I think as well it's really important that we hear from the young hemi-adults. And we've had a chance of our wonderful young hemi-adults there that you can see at our recent conference. And we had an Ask Me Anything panel. And the young people all shared very similar attitudes. They said, yes, the disability of having a hemispherectomy surgery is real, and yes, they face challenges, but the disability is a part of them, it's a part of their life, but the relentless seizures that they had before were so much more disabling to each and every aspect of their life, to the point where they said they didn't have a life, they weren't able to pursue their sporting goals, or getting a job, or getting a girlfriend or a boyfriend, or living independently, being able to seek the education that they wanted. So we find that with our young Hemi people, they share their strategies of strength and overcoming challenges, and they work through challenges to find ways to adapt. They find strength in their adversity and support with their fellow peers. They become the community they need, and these young people really help new parents that are coming into with the news that their child may need a hemispherectomy. And that's really powerful, and it's a great space to be in. We know that hemispherectomy care is complex and lifelong, and we can support decisions and work together. We will get those better outcomes for the child, especially if we don't delay his surgery as much as we've had in the past. Just finally, because I've got very limited time, if you would like to learn more about HFA, please feel free to scan the QR code. It will connect you to our website, social media, and newsletter sign-up form. As proud recipients of a recent Commonwealth Government grant, we're excited to be experiencing growth in our foundation, and we look forward to sharing how much hope can be found in one hemisphere. Thank you.
Now, we're nearly towards the end of time, and thank you, Carolyn and Kelly, for sharing those stories and also the insights and the work. And thank you for the work you do as part of the Hemispherectomy Foundation. It's such important work for families, and I can only imagine how many families reach out to you during their journeys at the different points along the line, particularly when it comes to those difficult decisions. Is there any questions at all for Carolyn or for Kelly, or any comments at all? Over to you there, Jenny. Thank you.
Thank you both. It's always really powerful to hear somebody talk from their lived experience. Thanks for that. I just had a question whether you could say briefly something more about what support you got from clinicians in making that decision, and in particular if there's anything that was an approach that was particularly helpful, or something you would have liked that you didn't receive.
I'm reflecting on an experience from 15 years ago, so I'm hoping things have improved, but we didn't feel particularly supported with our decision making. I think it almost felt like there was no decision to be made, because she just continued to become so unwell, and there were just no options. If hindsight's always. Whatever they say hindsight is. But I regret not going to the surgery at least 2 years before we did, and knowing what I know now about the research that clearly indicates that a longer duration of seizures prior to surgery is correlated with poorer outcomes. I wish I had that information, because we would have really used that to say enough's enough. I wish I knew that the research that indicates if 2 anti-epileptics aren't holding it, 6, 7, 8 ain't going to do it either. So I feel like the decision was really left to us to make, to the point where there was no decision to be made.
Do you want to make a comment? Okay. Yeah. I think it's really important, Jenny, because I think there's lots of information that's coming through, even from the work that Carolyn and Kelly have done. It's very valuable for clinicians to hear about timing of surgery, or what's really important in terms of that consultation at that particular time frame. We've come to the end of this. You want to ask a question? Sorry, Adam.
Oh, thanks,
Off you
Tom.
go. Yeah, we'll give you the lucky last question.
Thanks, Carolyn and Kelly. It was a really powerful story that you have about your families and your kids. We at the hospital are, I guess, in the business of trying to treat these wicked conditions. Me and lots of us in the room have worked with families who have just had, refractory seizures are just awful. But we're also in the business of like trying to, John Massey and I were talking about this yesterday, how you talk to families is really important, and being sort of realistic and hope and all that stuff that's in there. But I was interested in something you said, Carolyn, and that was about that Freya defied all expectations. Can you talk a bit about like what that's like? If you could sort of go back, would you sort of hope that things were a bit different in the way Freya's future was framed? Or has that just been like, I don't know, just curious.
Definitely. If I'm being really frank, absolutely. It was pretty dire and grim, the picture that we were given about Freya's future. It was very, very deficit-based. We had a neuropsych assessment done pretty shortly after surgery, and I look back and thinking that was really inappropriate. She had just had major brain surgery. Of course, her cognition's not going to, be that flash hot. And on the basis of that, we were said mainstream, probably not. I wish we were said, look, she's just had this major operation. You've got to leave time to, things to settle. Let's do a neuropsych assessment of 1 year post-surgery. We were told that her spatial deficits would be so severe that she wouldn't be able to navigate herself out of a room. So that was really confronting to hear, because I thought, well, how's she ever going to be able to participate in life, really, if they're that severe? I guess I wish, that we were put in touch with other families, so I could know that wasn't the reality for all. And I know that Freya has had a very good outcome. She has the etiology that probably in terms of cognitive outcomes do best after hemispherectomy, because kids that get Rasmussen's, typically around the age of 6, she was 6, have that period of normal brain development that other etiologies often don't have. So they do tend to do better cognitively. So I guess we're in that cohort that we knew that she could do the best. Physically, I look at Mikey. He runs and jumps and hurdles. Freya can't do any of those things. But so they've all the kids have different strengths afterwards. So Mikey's had a much better physical outcome than Freya. But Freya probably on the cognitive side of things. So in answer to your question, Adam, yes, I do wish things had been framed differently to us at the time. And I think I wish I had more information which would have influenced our decision making to go to surgery earlier and not pursue what I now know were futile treatments.
Thank you very much, Carolyn. I think we've come to the end of the session today, so it just leaves me to thank all the speakers and your participation in the discussion, and we look forward to tomorrow's sessions as well. So thank you very much, everyone. Thank you.